Then thank you very much, Dr. Shaima, for this very nice, valuable, really informative lecture. And I'd like to thank my dear Professor Mazen Naga, and I'd also to thank deeply Scope Medical Company, the official agent of Pentax and Cook Egypt. And now it is a time of free discussion and asking questions. Mr. Ashraf El-Bouhi and Mr. Adil from Scope Medical Company will control the process of asking questions. Please.
Before starting our discussion and the questions, I'd like to thank all the participants. Special thanks for our distinguished professors for their elegant, comprehensive, and informative lectures and illustrations. And very special thanks for those participants from different countries. They are from more than 50 countries all over the world. And now we are going to start our first question for Professor Hussein Aukasha. Is there difference between linear and radial echoscope in diagnosis of subepithelial lesions? This is from Dr. Muhammad Shaheen.
Yes, a very nice question. There is no different diagnosis, but in the radial is more easy. Radial echoscope is easier than linear in diagnosis of submucosal lesions. But if you have both acquainted or more experience with linear, after doing 50 to 100 cases, for example, you will be very easy to characterize and to diagnose submucosal lesion. Both are very effective, are very variable, no difference, but the radial echoscope easier at the start, in the beginning. But the most advantage is a very valuable role of linear is to obtain FNA if needed. So if I have a choice to buy one endoscope, I will buy a linear one. If I have another budget to buy another echoscope, I will buy another linear one. Because if the previous one or there is an in the maintenance, then I have another one. So in my lecture, the first slide is the main task, and the most valuable role of endoscopic ultrasound is tissue sampling and tissue acquisition, the linear one. Because in most cases, as I mentioned, tissue is the issue. So if you have a linear one, don't bother yourself, be panic. Just do cases, reach out 40, 50 or cases, and you're very acquainted with submucosal lesions, and there is no difference at all between the linear and radial one.
Second question. For an unknown solid pancreatic mass, you recommend an FNA or FNB? Which gauge?
Pancreatic?
Pancreatic mass. For unknown solid pancreatic mass, would you recommend an FNA or FNB? Which gauge?
Yes, a very good question. Yes, a very good question. If the mass is straightforward or looks like a pancreatic adenocarcinoma, you can diagnose it, suspecting it strongly by just the endoscopic picture, obstructive jaundice, head mass, hypovascular mass, hypoochoic mass, then it is mostly a adenocarcinoma, which constitutes about 90 to 95% of all pancreatic mass. Here, FN is very efficient, as FNB. Both are equal. If you are acquainted, or if you are your preference is FNA, do FNA. But if mass is somewhat typical, you are suspecting coma, or you are suspecting autoimmune pancreatitis, the patient is have another autoimmune diseases, the pancreas is sausage shaped in the 5% of cases, then you should do FNB. But in most instances, the picture is very informative or very important of pancreatic ductal carcinoma to both are equal in about 90% of cases. Atypical cases, as I mentioned, when you are expecting lymphoma or autoimmune pancreatitis, then you should be because you should do staining. Sure, you should do FNB. So most of the pancreatic cases, I am doing FNA. The echo tip needle very malleable, very easy to relate with the lever, the elevator. So I am very comfortable with FNA. But at the end, as you are your preference, many of the colleagues doing sampling by FNB. All are FNB. This is his preference, but my preference is FNA. FNA needle is very malleable and very easy to manipulate in the duodenum. But I refer to FNB if I am think that I will need immune staining, as I told you, in pancreatic masses suggestive of lymphoma or immune pancreatitis.
Next question is for Professor Mazen Naga from Professor Tahir Zanati. In papilla within diverticulum, usually there is an anomaly in papillary muscle, either very short or malrotated. How we can avoid perforation?
In papillary inside diverticulum, the European Society of Gastroendoscopy recommend putting stent inside and then cutting over it. But I don't do that. Usually, I cannulate with a regular sphincterotome and then very short cut, except if I see the whole papilla. Unfortunately, the time does not allow me to present several cases of different views of periambular diverticulum because this is variable. Maybe on the right side, which is rare, maybe on the left side, which is more common, maybe on the floor, you can cannulate directly or looking the orifice to the other side. There are many different shapes, but as long as we are inside with the guide wire sphincterotome and the wire is inside the common bile duct, I can make a shortcut followed by balloon dilatation to avoid perforation if I can see the upper limit of the papilla.
Next question for Professor Mazen. How to differentiate submucosa and sphincter muscle to avoid perforation during pre-cut sphincterotomy?
As we see in the videos, we shorten the needle as much as possible and we start by cutting the mucosa. Even submucosa is cut during this procedure to expose the muscle layer. The main issue is that we must not push the cannula with the tip of the guide wire into the recess formed by the retraction of the mucosa to the outer side. We must restrict our functioning to the muscle layer, which is completely directly under the mucosa. So when we cut the mucosa, if we didn't expose enough of the muscle layer, we cut more. We can cut up to the upper limit of the papilla to expose the muscle layer. There is no risk of perforation. Then we cut the muscle layer as we want, but avoid to try to use the wire in the recesses formed by retracting the submucosa to the sides because perforation is very easy at that time.
Thank you, Professor Mazen.
Thank you.
Next question is for Dr. Shaima.
Yes.
Dr. Shaima, is there any underlying fibrosis in UC patients led to more difficulty in ESD, or
yes,
it is
yes,
like
yes, of course.
other patients?
No, of course, this patient has a mucosal inflammation, and it is expected that he goes into a lot of attacks of exacerbations. So there is, by default, an expected submucosal fibrosis. That's why patients with ulcerative colitis, they are mentioned clearly in the Japanese guidelines that whatever the size of the lesion, it should be removed in block.
Next question is from Professor Khalid Hameda to Dr. Shaima. What is What is the incidence of stricture after EMR, especially after removal of large circumferential lesion in esophagus and colon?
Could you please raise your voice? The
What
instance of stricture?
of stricture after EMR, especially after removal of large circumferential lesions in esophagus and colon?
Actually, the instance of after circumferential lesions for EMR is not that high like ESD, because in ESD we use a lot of coagulation, and we can also use an APC. But there are a lot of trials that these patients can have an oral steroids that should be started immediately after the procedure. And sometimes when stricture happens, we can give them an intralesional steroids.
Okay, next question is for Professor Hussein Okasha.
Can you please raise your voice?
Okay, thanks. Seriously.
Dr. Ashraf, please raise your voice.
Okay.
We cannot hear you clearly.
Is it must to use a stopper during the EUS-FNA of thickened stomach wall with an impressive malignancy for the concern of potential peritoneal seeding?
Please repeat the question.
Is it a must to use a stopper during the EUS-FNA of thickened stomach wall with the impressive of malignancy for the concern of potential peritoneal seeding?
Yes. That's a very intelligent question. You mean that we use the stopper to prevent past pointing of the needle outside the gastric wall into the peritoneum. So you may translocate some of the malignant cells from the gastric wall to the peritoneum.
Exactly.
Yes. Actually, I don't use the stopper at all because my little finger is the stopper. I don't use the stopper in usual cases because I am fixing my little finger at about 5 or 6 or 7 centimeters, and it acts as a stopper. And my index finger and my big finger are doing the movement to and fro movement. I use the stopper only in 2 cases. The first case I mentioned in the lecture, in the knocking door technique, because I am doing successive severe pushes, so I should fix the stopper 1 or 2 centimeters below the handle, according to the size of the needle, to do this staccato or strong pushes. The second situation which I use the stopper is when aspirating a pancreatic cyst. I am entering the cyst, start aspiration, and I fix the stopper because I will spend up to 10 minutes in aspirating the whole content of the cyst. So, in a trial to avoid any unexpected movements of the patient or of the nurse, so I fix the stopper to prevent past pointing of the needle to go out of the cyst to the opposite side. But in the usual cases, in most of the cases, I use my little finger fixing the shaft of the needle and acting as a stopper. This is in most of the cases.
Thank you, Professor Okasha. Next question is from Dr. Abdelbasit Al-Khamri to Dr. Mazen Naga. When you do indifferent cannulation of the pancreatic duct, how you decide to do either double guide wire cannulation of the CBD or transpancreatic sphincterotomy?
I rarely do transpancreatic sphincterotomy because the hazard of pancreatitis, although we are trying to do septotomy only, is greater. So I leave the wire inside. I then cannulate the bile duct. But if the papilla is very small, and especially also if it is under a fold, which means that leaving the wire inside make it more difficult to cannulate again, so I do transpancreatic sphincterotomy. Also, If the papilla is malrotated to one direction, making positioning also difficult, then I will do transpancreatic sphincterotomy. Small papilla, under a fold, mal-directed, but in also if the wire is not deep enough inside the pancreatic duct to avoid that the wire making kink and slips outside, or to make perforations pancreatic duct. So if the wire is not long enough inside the pancreatic duct straight, this is the third indication to do transpancreatic sphincterotomy.
Thank you, Professor Mazi. The next question is for Dr. Shaimaa. In case of non-lifting lesion due to fibrosis or by previous biopsy or EMR, how to differentiate this from invasive before performing ESD?
Yes, this is a very good question, and I will take a little bit time to answer it. Basically speaking, whether this lesion is fibrosis or recurrent or not, how to identify that this lesion is malignant, and how to identify the layer. I know that in the guidelines that it's not mentioned that we use EUS, but actually we use EUS to identify the layer of the lesion. And we think this is mandatory according to our experience to know the exact layer that will help you in knowing provisionally if this lesion is benign or malignant. But what is much more important is to use a high definition scope. The use of high definition scope can help you in detecting if there is an invasion or not. So it is recommended in the guidelines that you never do ESD or EMR without the use of high definition scope with narrowband or chroma endoscopy. We had a lot of classifications. We have Paris classification, we have the NICE classification, and also we have that the NJET, or sorry, the GNET, or the Japanese classification. It helps you to roll out the invasion with the presence of a special surface pattern. But if we go deep, that we have a lot of other classification system according to the blood vessels that are apparent on the surface. And if you allow me that to share you a little bit, can I share my screen again, or we don't have more time?
We still have time.
Okay, so as you can see here, this is the IPCL-AB classification. It gives you an idea about the exact layer and whether the depth of invasion. Actually, this needs a lot of training, and it depends on the capillaries and the looping of the capillaries. And also we have another system, or another classification system that's called EVA, which is the avascular area. And also it helps you to give you an idea about the depth of invasion. But these lesions, these systems need a magnification endoscopy, and this magnification endoscopy is not available in Egypt. So we don't have other options. So we will have to depend on the surface, on the surface that I mean roughly from the chroma endoscopy or from narrowband, and not from the blood vessels. That we can use the Kudu classification, we can use the NJET classification, we can use the NICE classification, of course the Paris classification. Okay, thank you.
Okay, thank you, Dr. Shaimaa. For Dr. Okasha, from Dr. Salim, can you explain the difference between...
Please raise your voice again.
I'm sorry, maybe this is a device. Can you explain the difference between door knocking technique versus capillary technique in FNA?
These are two different techniques. Capillary technique is a low pressure technique, I mentioned it. Low pressure technique or capillary technique or slow pull technique, these are synonymous to the same maneuver. Where the capillary technique, when you enter the mass and doing the to and fro movement, at the same time your assistant is withdrawing the stylet 10 by 10 centimeter. So you are creating a very low pressure inside the needle. This capillary technique or low pressure technique or slow pull technique is very suitable for vascular lesion. to avoid bloody smears. If you apply high pressure to a vascular lesion, then we'll suck more and more blood with dilution of the specimen, and finally it will be inconclusive. So as I mentioned, capillary technique or slow pull technique or low pressure technique is very suitable for vascular lesions, as some cases of gastrointestinal tumors, GIS, or neuroendocrine tumor. But the knocking door technique is another technique for another situation. When you find that the mass is very firm, and after you piercing or entering inside the mass and starting to do to and fro movement, you find that the needle is not moving inside this hard mass. When you move the needle, it does not move inside the mass, but it is shaking the mass as a whole. So no biopsies were taken. By then, you should apply the door knocking technique. Successive staccato pushes in order to push the needle to move inside that hard lesion. So these are two different techniques in two different situations.
Okay, thank you, Professor Akasha. Next question is for Professor Mazen from Dr. Ahmed Dawood.
Please raise your voice again in every question.
Okay. This is for Professor Mazen from Dr.
Yes.
Ahmed Dawood.
Yes.
Did you use surgical clips to help in cannulation of CBD if the ampulla is in diverticulum?
Yes, I use it sometimes, but as we all know, eclipses are very expensive now in Cairo. So I prefer to, in the condition like this, to inject in the floor of the ampulla more cheap with the needle. But we can use it if there is redundant folds to fix the folds to bring the ampulla outside. But now, not so common because of expense.
Thank you, Professor Mazen. Next question is for Dr. Shaima.
Yes.
What is the rule of ESD in Barrett's esophagus?
What is the rule of course, when there is a suspicious lesion, if the lesion is like nodules that are less than 15 millimeters, this is according to the guidelines, it can be removed safely with EMR. When there is a suspicious area that there is a deeper invasion, it should be removed with ESD. And if it is more than 15 millimeters, it should be removed with ESD.
Dr. Hussein Okasha.
Yes.
This is from Dr. Ahmed Mustafa. Sampling of nearby port hepatic LN may help us knowing nature of
sampling of nearby. Yes. Raise your voice.
Port hepatic LN
lymph
may
node.
help
Yes.
lymph node may help us knowing nature of proximal hilar stricture. What is
Yes.
the rule of cytology brushing, especially if I don't have spyglass?
Yes, it's a very important question. If the patient underwent ERCP before for application of a stent or something like that, and you find a hilar stricture, then you can do brush cytology or bile cytology. But unfortunately, the yield of brush cytology is very low. It is about 30%, and the false positive is high. So it has a very low sensitivity and also low specificity. So at the end, you should have another technique for tissue sampling. In case of hilar stricture, here of choice is cholangioscope or spyglass. And then comes EUS-FNA in the third place. But if you don't have, if the brush cytology is negative, and usually it is negative, so some professors do not do it from the start. They are saying, why I am not doing a technique which is maybe costly and have a very low sensitivity and rather low specificity. But some are doing brush cytology. But you can reach the diagnosis in only 30% of cases. So you need another modality for tissue sampling. In case of hilar stricture, the first choice is spyglass and cholangioscopy. And in distal stricture, the first choice is EUS. But if you don't have spyglass or cholangioscopy in your section or in your institute, and there is no other facility to refer it to another unit, then we come to the third option, which is endoscopic ultrasound, which also usually fail to obtain biopsy from the hilar lesion, because in most instances, up to 80%, it is in the form of just wall thickening. But to overcome this, we can sample a nearby lymph node. If it is Klatskin tumor, hilar cholangiocarcinoma, in most cases, there is a nearby lymph node because it is a malignant lesion. It is very easy to sample the porta-hepatic lymph node, as we saw in the videos in the lecture. And if it is positive, this will be a very useful indirect sign of malignancy of this hilar stricture. We did many cases. We reach now up to 37 cases of hilar stricture diagnosed by malignant porta-hepatis lymph node. 37, but 37 cases over about 15 to 10 years of working in endoscopic ultrasound, and it represents about 50% of cases of EUS done for hilar stricture. In 50%, in Klatskin tumor, in 50%, we can find lymph node and very easy to sample, and the cytopathology is very accurate, so we can reach the diagnosis indirectly in 50% of Klatskin tumor. Probably after reaching a large number of these cases, we can publish it, but till now it is just an advice to sample nearby lymph node because it is the most available in most cases.
Thank you, Dr. Hussein Okasha. Now to Dr. Mazen Naga from Dr. Muhammad Nabil Qadi. When to stop trial of cannulations?
We usually stop trial of cannulation if we found that the papilla is deformed and we will be more harmful than successful because the incidence of both ERCP pancreatitis will be increased by more manipulations. But this is not usual. This is very rare because after a trial of cannulation, usually we shift to pre-cut, and the success rate in pre-cut only maybe 2 to 3% of the cases shifted to pre-cut are failures, which means that success rate as usual cannulation is around 90%. 10% will shift to pre-cut, 2% of them will fail, and then we shift to another maneuver like BTC or rendezvous technique or to EUS with rendezvous technique.
Next question is for Dr. Shaima from Dr. Ashraf Abu Bakr. How do you know if the layer of invasion in areas far from EUS axis? And
Yes.
if you accidentally find the muscle layer during ESD, do you continue?
Yes, this is a very good question. Maybe I partially answered the question from the previous question that it's not the EUS that we usually depend on when we want to characterize the lesion, but it is usually very helpful when it is in the EUS axis, right, in the esophagus or in the stomach or in the rectum. But the question comes when the lesion is in the proximal side of the colon, on the right side of the colon, or on the transverse colon, or maybe on the left side where the EUS is not accessible. Here we have mainly to depend on the high definition scopes and the use of narrowband and the use of classification, and we can roughly estimate the depth of invasion, or at least we can exclude invasion. So this is how we depend. If we have magnification endoscopy, it will increase the sensitivity up to more than 80% to detect the layer of invasion.
Thank you, Dr. Shaima. And
yes,
now
about the second part of the question is when you find, if you find invasion, yes, we will have to go on, provided that we are fully equipped with, because we started the lesion, we cannot stop, but we have to go on and we have to complete it, because sometimes there is a fibrosis that can be mixed as an invasion. So we have to go on and complete the lesion. And the final decision will be to the pathologist to decide whether this was really an invasion to the muscle layer or it was just a fibrosis extending. But it's an advice that we perform tattooing of this lesion, because afterwards, if we found that it was a little bit more invasive, so it would make the surgeon job much easier if we do a tattoo.
Thank you, Dr. Shaima. Next question is for Professor Mazen Naga from Dr. Mahmoud Gouda. In case of a short part of the guide wire could pass through the papilla, but not kinking and not passing through the CBD, can we inject a dye to be guided?
Yes, this technique of roadmap we use if the wire does not pass enough inside, but we must make sure that we inject slowly and small amount to avoid overfilling of the pancreatic duct. The problem is that we must repeat very cautiously, because every time we inject again, we have the same problem again. But what we can do, if we have two screens beside each other, one for working and one for fixing the photo. So we inject a little bit, we have the roadmap, fix it on the other screen, and then we manipulate according to the position seen on the fixed screen.
Next question is for Dr. Okasha.
Can you get close to the laptop, please, Dr. Ashraf, because we barely hear you.
To Dr. Hussein Okasha from Dr. Mumtaz Hussein. What is your experience in sampling portal vein for cold biopsy of cancer cells to pick up early pancreatic cancer? How safe is it to transverse the portal vein?
Yes, I didn't do it, and I am not so encouraging to do it. It is safe, but I think this maneuver is not so asked. No one requesting this. Requesting portal vein sampling. Maybe there is no such research in Egypt, but portal vein sampling is rather safe. But really, I didn't do it before, but it is easy. It can you reach it through segment 4, through the right lobe of the liver. But I didn't do it before. And some are doing sampling of portal vein thrombosis, thrombus inside the portal vein before transplantation to know whether it is a malignant thrombus or benign thrombus. But I think very good quality CT scan, triphasic CT, very good quality MRI, very good quality especially CT with reconstruction, and it can solve the problem without the need of doing this maneuver. It can be done, rather safe, but no one asking for this technique so frequently. And I think regarding portal vein thrombosis, good quality triphasic spiral CT with reconstruction and IV contrast is enough to differentiate benign from malignant thrombus.
Thank you, Professor Okasha. And now to Professor Mazen from Dr. Osama Salem. In case you put a pancreatic stent, what is the length and size you use? How frequent you check on it? When to remove?
There is two pancreatic stents. One as a prophylaxis against pancreatitis. This is 5 French stent, and I put short stent to fall rapidly. The main aim is to avoid blocking the pancreatic duct from the early edema occurring during sphincterotomy. So no need to stay longer. Usually I check for it by X-ray after a week. The other stent is that used for treatment of strictures in pancreas and chronic pancreatitis, and this I will leave for 3 months.
Thank you, Professor Mazen. For Dr. Shaima,
Yes.
concentration of the methylene blue and saline for elevation of mucosa in ESD from Dr. Fatma Adil.
Yes, we use 9 millimeter concentrated methylene blue on a 500 cc saline.
Thank you. For Dr. Shaima also, do you use EUS before doing ESD or not, for elevation?
Of
I am
course,
watching.
Professor Okasha.
I'm watching your answer.
Of course, we use EUS before everything, before meals even. Of course. Especially if the EUS is from Pentex, we have to use it every.
Thank
course,
you.
Of course, Professor Akasha will kill us. As you can see, that from our local experience, of course, it's not very huge experience, but we usually perform whenever accessible EUS for all lesions, because we have to assess the lesion very thoroughly. We are still gaining experience, and we think that EUS should be performed, and even performed by experts.
Okay, thank you, Dr. Shaima.
Yes.
Another question for you from Dr. Tahir Zanati.
Yes.
Why you mark the lesion before submucosal injection? Can we inject first to be sure that it is lifted before marking?
Yes, very nice question. Actually, we don't depend on the lifting sign. It could help, but the sensitivity and specificity of the lifting sign had proven to be of little value if you want to detect the lesion is benign or malignant. So it's better that we already had taken the decision to remove the lesion before we try lifting. This is very important, especially if we don't have the ESD equipments around. If we try to lift the lesion first, and then we found that, oh wow, that's lifting, so we will remove it somewhere else, it will cause an extensive submucosal fibrosis. So lifting sign is a good help, but it's not sensitive or specific. We have to depend on other things like EUS, like the external morphology of the lesion, to take the decision whether to resect the lesion or not. About marking the lesion, we have to mark the lesion first, because before starting the dissection, everything looks calm, there's no blood, there's no blah, blah, blah. So we have to define the actual margin between the normal tissue and the abnormal tissue. So we can put our margin, because once we start the injection or putting the needle, or once we start the dissection, everything goes with blood. It's not that clean like we have showed in the videos. It's an edited videos. So these marks will remain our guide till the end of the procedure.
Thank you, Dr. Shaima. Next question is for Professor Mazen from Dr. Mustafa Kilani. What is your opinion, Dr. Mazen, about limited sphincterotomy and balloon dilatation of papilla?
Yes, we use this in case of large stones to preserve some of the sphincteric function, to be able to remove the stones. So we do limited sphincterotomy to avoid pancreatitis and to inflate the balloon above the pancreatic orifice to size comparable to the bile duct diameter, and then we can remove all the stones. And this is preferable to lithotripsy, because lithotripsy must crush all the stones. But if you balloon dilate, you can extract all the stones by single balloon dilatation. No need for crushing multiple baskets.
Next question is for Dr. Okasha. Patient diagnosed endoscopically to have adenocarcinoma, CT showing regional lymph node enlargement. Is this a case indicated for lymph node EUS biopsy?
Yes, the patient is already diagnosed as gastric adenocarcinoma. Those patients were sent for staging, not for biopsy, of course, because it is already diagnosed. And I don't sample primary first station lymph nodes, because it will not affect the diagnosis. But if there is a secondary station lymph node, I should sample, like celiac lymphadenopathy or mediastinal lymphadenopathy. But this policy has changed in the last few years. Now the guidelines for surgery or neoadjuvant chemotherapy is stage T1N0. So, in order to do surgery for esophageal or gastric, the patient should be T1 or T2 without lymph nodes. If it is T3 or T4, or there is a nearby lymph node, then the patient should have neoadjuvant chemotherapy and then surgery. So nowadays, when I am doing staging of the patient and I find it T1 or T2, and then T1 or T2, then I go for node, then I should sample it, because if it is a malignant, then the patient should go for a neoadjuvant chemotherapy. Now the neoadjuvant chemotherapy has a great role. Neoadjuvant chemotherapy, the word neoadjuvant means preoperative chemotherapy for downstaging and then surgery. This is the meaning of the word neoadjuvant. So neoadjuvant chemotherapy are now given for all malignant tumors more than T2 or have any first station and of course the second station's lymph node. So when the patient referred to me for staging of already known case of adenocarcinoma and I find first station lymph node, this may be inflammatory or desmosplastic lymph node, which are commonly found in malignant lesions, or it may be a metastatic. So I should sample it, because if it is positive for malignancy, then the patient should have neoadjuvant chemotherapy before radical surgery.